under the so interestingly named Patient Protection and Affordable Care Act. This was based on a mandate model. The employer mandate was first offered by President Nixon in the 1970s, and then the employer and individual mandate were Republican proposals during the 1990s. What we got was a Medicaid expansion. So we expanded the income level up to which patients can qualify for Medicaid. We have a mandate for those who do not qualify for public programs to purchase private insurance, and we're using our public dollars to help them purchase that private insurance, although there are no premium caps on that private insurance. So we're pouring our public dollars into the private industry, that very industry which wrote the legislation and to their benefit. And what did they get in return? If they agreed to the individual mandate, or if we agreed to the individual mandate that we would have people purchase their product, that they would accept some regulation. But how well is that working out? Just recently we saw on Thursday that with the 6-month anniversary of the legislation, one of the provisions that kicked in was that they can no longer deny new policies to children 19 years of age and under who have a pre-existing condition. So what are the insurance companies doing? On Wednesday we saw in the LA Times that Anthem, Blue Cross Blue Shield, and Aetna and other insurers have decided to drop new policies to children under 19 years of age because it's a product. For insurance companies, it's not about health. It's about selling a product, a health insurance product. And if you're a business and that product is no longer beneficial to you, then you have no reason to continue to offer that product. We're the only nation that uses this model of health insurance. The other countries that have private insurances use a very different social insurance model. So what are we expecting? More of the same, although we're spending a lot more money for it. So what are we talking about when we say single payer? We're talking about true health security, that we're taking care of the people of our nation and that they know when they're ill that they can be cared for, every single one of us. So it's a unified risk pool, everybody in, nobody out. Not only does that make the most economic sense, it makes the most sense from a public health standpoint, because we're at risk for infectious diseases and our social well-being suffers if not everybody can get care. Everybody contributes based on their ability to pay. We need a progressive financing of our health care. Right now we rank 54th in the world for fairness and financing of our health care. We have a very regressive system. All medically necessary care is covered. Why would we cause people to be denied medically necessary care so that a corporation can make a profit? That seems very unethical. We can save money through simplified administration, so we can, by going to a single pool, instead of wasting 1/3 of our healthcare dollars on all these different insurance companies, there's one entity to deal with. And so we can significantly streamline our administrative costs, giving us money to pay for those who need care. And through this system, we advocate that we can focus more on preventative and timely care. We have lots of studies showing that when people have to pay copays or deductibles, they make poor health decisions. They choose to put off care that they should otherwise receive, and so too often end up in the emergency room. That 42-year-old that has a stroke because he couldn't afford his antihypertensive. You know, that diabetic who ends up in DKA because they couldn't get the insulin that they needed. That's not a very good way to take care of our population. It's not good from a health standpoint or from an economic standpoint. And then, of course, what we want is transparency and accountability. We don't have that in our current situation. The insurance companies, when you look at what's paid out for different services, there's actually no rational basis behind it at all, and it's very hard to find out how these decisions are made. So what I'd like to do is just run through the Patient Protection Affordable Care Act quickly and our legislation, which is H.R. 676, Expanded and Improved Medicare for All, and just compare them on a number of parameters. So universal coverage, the PPACA is expected to leave 23 million people out in the year 2019. And as you probably know, the insurance exchanges and many of the provisions don't kick in until 2014. So in this 4-year period, that number of uninsured is still going to be remaining uninsured and likely growing in terms of the number of uninsured. With H.R. 676, every person who resides in the country is part of the health system. Everybody in, nobody out. What about cost containment? Well, what we've done with this legislation is we've increased the amount of administration that we have. So now we have to have people that can enforce the mandate. We have to have people that develop and run these exchanges. And our experience with the exchange in Massachusetts is that it adds about 4% to the premiums for that entity to oversee that. Of course, we have outlays for increased coverage. But any of the cost controls that were put into this legislation, none of them have been proven to actually control costs. The information technology, preventive care, preventive care actually increases cost, but it increases health. Whereas HR 676, we streamline our administration so we have that savings each year, but we also, a key provision is the fact that we become a monopoly. We are a large single purchaser of products, and so we can negotiate for fair pharmaceutical prices, for fair medical device prices, and we can set budgets for hospitals so that we've gotten into this game now where hospitals have uncompensated care, patients that are coming in that can't pay, so hospitals have to stay open. How do they do that? By generating more profit, by having more services, many of which are questionable whether they're necessary or not. And we see this in our physician population, physicians that are being pressured to order more tests, to order more procedures. We see primary care docs that are taking up practices that they can bill for, procedures, removing lumps off the skin or things like that, so they can keep their practice open. Affordability for the American person under the PPACA, there are no caps on premiums. And so what we anticipate is that we're going to see growing underinsurance, a trend that is already on its way up. Almost half of policies on the individual market that are purchased on the individual market are underinsurance policies. And we're seeing this in our employer policies as well, where in order to save money on the premiums, they shift more of the cost onto the employee in terms of a greater share that they're paying for that premium, or perhaps higher deductibles or higher copays. The PPACA has 4 tiers of coverage. There's like platinum, gold, bronze, silver, whatever. The lowest one is only expected to cover about 60 or 70% of our healthcare costs, so that significantly underinsures our patients. Under HR 676, there is no cost shifting, no cost sharing, there are no copays and deductibles. People don't have to pay first dollar for care because that makes the most sense. We would have progressive financing, and for most people, they would be paying less out of pocket in taxes for the system than they would be paying currently for premiums and copays. Comprehensive benefits. Well, as I said, there's tiering of covered benefits under PPACA, and so patients are still going to be getting the amount of health care that they can afford. Whereas under HR 676, it is comprehensive. It covers all medical, dental, vision. You can see it in their prescription long term. And most importantly, it's a single standard of care for everybody. A year ago, September, during Health Justice Week, we put American flags up on the Washington Monument. We had just released a study of how many Americans, adults who are uninsured, die because of their uninsurance, and it was 45,000 a year. So we put flags down, and for a week we were there, and we had people coming by, and the people that stopped by from other countries just couldn't understand how in this country we allow this to happen. One gentleman from the UK said, in my country, the person in the mansion and the person living on the street have the access to the same health care, and that's how we believe it should be. Free choice of provider. This debate, so-called debate, was framed as choice. Americans want choice. Americans don't want choice of health insurance. Americans don't understand health insurance. So what you want is something that's going to be there when you need it. So what we're going to see is continued restriction while you have choice of health insurance, continued restriction in your choice of provider, choice of where you go. And this is one way that insurance companies can do what we call cherry picking, where they weed out the sick by restricting their provider networks so that people can't get to certain centers. If you have a condition and your insurance doesn't cover the cancer center, that's a problem for you. Under HR 676, all providers are in. If you're traveling, you can be seen where you're traveling. You have choice of physician. You don't lose your doctor because your insurance company changed its network or your employer changed its policy. Quality of care. It's highly variable whether this will improve under PPACA because it is, again, based on your ability to afford to get care. And it continues this very fragmented system that we have. You can have great IT, but if you don't have a single system to really oversee it and make it work coherently and protect patient privacy, that becomes a problem. We're still going to have difficulties with communication. Under HR 676, we expect quality of care to improve for a number of reasons. Simply one being that everybody can get care, they have access, there's continuity of care, no more financial barriers to care. here's a concept, we can allocate our resources based on a rational basis, based on where they're needed, which is what we see done in other countries, as opposed to here, where it's so often in our cities, we'll see that there's duplication of services because one group will see that this hospital is doing all these MRIs or this new technology, and they'll be like, well, we've got to have one of those over here so we can compete with that hospital and draw patients back to our hospital. So we have too many resources in some areas and not enough in others. And treatment would be determined by patient and the physician, as opposed to an insurance company administrator telling you whether your patient can have that test or that medication. Something that's incredibly important. And then what we see in other nations is that when the nation is paying for health care, it changes your public health policy, because you can save money by enacting policies that give you a healthier population, by removing toxins from your consumer products, by no longer allowing subsidies to high fructose corn syrup. If you go to Europe, it's very hard to find high fructose corn syrup in their products. My children didn't love that, I did. Improve public education, improve public transportation, these types of things become more important. What about equity? We're the only nation that doesn't, industrialized nation that doesn't use a human rights framework for its healthcare. Those human rights frameworks, principles are universality, equity, and accountability. Under equity, we see that there's tiered care. So we're likely to continue to see health disparities. Under HR 676, as I said, it's universal, a single standard of care. And if we look at our traditional Medicare, we can see that in this country our health disparities rise until our population hits 65 and they go into Medicare. We start to see the health disparities, that gap close. Bureaucracy under PPACA greatly increased. We're going to continue to have all of these different insurance companies, all of these different layers. Under HR 676, greatly reduced. And in terms of sustainability, why do I say that it's designed to fail? Well, we've seen similar legislation play out at the state level over and over, and each time it's not been able to achieve the coverage that they've wanted to achieve, the goals, and they've become financially unsustainable over time. Under HR 676, we actually create a national framework. Single payer gives us the financing to do that, but the framework is important in order to have something where the incentive is health, not profit, and so you can evolve. And that's very much the French system, which, while it looks like a multi-payer system, functions like a single-payer system, and they're constantly tweaking it based on the needs of their people. And that's what we should really be thinking about, is tweaking it based on the needs, not tweaking it based on what the industry will allow us to do. So, in conclusion, I just want to say that I believe we should really, it's a matter of professional integrity for us to be advocating for the best health system that we can have in this nation. And I don't think too much about the political feasibility, because political feasibility is something that changes with the mood. And we're responsible for changing that mood and demanding that we have something of practical feasibility. Thank you.
Of the people will not be denied.
Running high from the rising tide.
Standing together, side by side. Running high from the rising tide. Needs of the people cannot be denied. Running high from this rising tide. No, you can't. Running high.